So, does anybody get the representation of my graphic on the front? What this is all about? There you go. We're the gatekeeper of dose. You're the future gatekeepers of dose. And that's really what this is, and what most people tend to forget, that we're the ones that are going to be in control of dose to our patients. When we look at risks associated with exposure, the big thing that's hammered in school over and over again is gonadal shielding. Constantly we look at, let's make sure the ovaries are shielded, let's make sure the testes are shielded, and we're looking at protecting future generations. If you go out and you look around, you'll also notice that our population is a whole lot older and we're living longer, so it's no longer just about those genetic effects. You need to worry about your body as well as your patient's body beyond them having children. And when we talk about the somatic effects, we have to look at skin, we need to consider thyroid cancers, we also need to look at the red marrow, bone marrow that we expose when we do our procedures, in particular if you talk about the skull, the sternum, the scapula, the pelvis, the vertebrae, and the epiphyseal ends of the long bones. I mean, how many of you, if I look at the students' knees, you see knees almost every day, and hips, shoulders, etc. We have a ton of exams that we do that involve red bone marrow. And the people, if they're coming in as a start for, oh, I have knee pain, then become oftentimes a frequent flyer, so they keep coming back until they have that joint replacement. And then even then, they'll come back afterwards for follow-up. So we have to consider, what are we doing to them over a 15-year run that they come in there? And if you're in an orthopedic office, they keep coming back unless they move away. So we want to make sure that we not only minimize that genetic exposure for what their future might be, but also their body itself. So our patient comes to us, we have to look at exposure factor selection, and if I said to the students, what's the most difficult concept that you had to learn? The RTs make it look simple, and that is, what about technique? How much do I use for this, and how much do I use for that? The RT, you know, after so many years, becomes the master of the craft. And we can look at a part thickness and we can decide what we want to use. We take into consideration tissue compensation. Am I dealing with bone? Am I dealing with muscle? Am I dealing with fat? Do I have contrast media in there? Did I put iodine in? Did I put air in? Maybe I used a little barium. But that's part of the whole process of figuring out what we want to use. And the other thing is, what's the pathology that's in our patient? Sometimes there isn't any, and other times almost all of our patients have some pathology that we need to address. Is it additive or is it destructive? All of those things, when you look at the experienced RT, are running through their mind to say, what do I need to use for my technique? How are you going to ensure ALARA with a digital system? Number one, first and foremost, I mean, when we sign off on our certification with the registry every year, we're saying we are going to adhere to professional standards and ethics, regardless of how long I've practiced. Every single one of my patients that comes through there, I'm supposed to do this. Second in line, work with protocols. And you know, rhetorically I'll say, okay, so how many people here have protocols in their department? And if you have the protocols in your department, are they adhered to consistently? And with that protocol, you want to have a defined range of exposure indicators. I don't know, I probably have 25 people in here. I can guarantee I'd get 25 different ranges. Okay, if this is acceptable, no, that's acceptable, no, that's acceptable. We can't be there. We have to nail this down so that we can keep in mind it's all about our patient. So, and the only way you're going to do that is you have to do audits. You have to follow behind and look behind the scenes to make sure everybody's doing what they're supposed to do. That's the case. It's like when you're out on the interstate driving down 40, nobody's going 65. I understand that. But when the police are there, everybody's going 65. Why? Well, you're being audited. You're adhering to the rule. That's the speed limit. State police are right there. And in this particular case, if you know that someone's going to follow behind, and somebody's going to, you want to make sure you stay in compliance with that. The responsibility, bottom line, isn't the medical physicist, isn't the radiologist, isn't the department manager, isn't the supervising radiographer on the floor when it comes down to patient dose. Patient dose is the RT. That's whether I'm the therapist, the CT tech, the nuclear medicine tech, or the radiographer. I'm in charge of dose. There's nobody that sits right behind me that says, unless I'm a student, you didn't set that right. Once you're certified, you're in control. You're the bus driver, and you decide where you're going to go with your dose. You're the gatekeeper, plain and simple.